We're going to invite Mrs. Eunice Adeoye, and she's the matron of the Golden Age home. She's Nigerian by birth and has been in Jamaica visiting Jamaica since the year 2006. She finally chose to call Jamaica home in 2017. She has extensive professional experience as a registered nurse, midwife, health educator, and nurse administrator. She's worked in various settings, in chronic settings, psychiatry, oncology, medical and surgical nursing, and has administered nursing care to persons of different age cohort. She holds a Master of Science degree in Nursing Administration from the University of the West Indies, as well as a Master and Bachelor of Education in Health Education from the University of Ibadan in Nigeria. She's a registered and licensed nurse midwife by the Nursing Council of Jamaica, as well as the Nursing and Midwifery Council of Nigeria. And so, ladies and gentlemen, let us welcome Mrs. Eunice Adeoye.
I want to appreciate the organizers for allowing me to give this presentation. So I'm going to be talking about the experiences and strategies used by care homes in meeting the care needs of the people with dementia. All right, like we all know, dementia, as we all know, is one of the consequences of the degenerative changes that occur in the brain tissue of older adults. And it imposes several burdens upon the carer, the family, and patients himself or herself, as we have heard from the previous presenters. Dementia is a syndrome in which there is deterioration in cognitive function beyond what might be expected from the usual consequences of biological aging. And it is also progressive. Around 55 million people have dementia worldwide. And as the proportion of older people in the population keep increasing, there is tendency for the number to increase. There is expectation that it will rise to 78 million in 2030 and 139 million in 2050. Dementia affects each person in different ways, depending on the underlying cause and other health conditions. Some have, like we've had, some have other comorbidities like diabetes, hypertension, even psychosis. And it also depends on the person's cognitive functioning before becoming ill. Nurses play key role in recognition of dementia, especially during admission while assessing the patient. And to give quality care to these categories of patients, there is need for us to be able to identify their priority needs. Some of the needs identified are cognitive needs, safety and security, self-care, psychosocial needs, communication, nutritional needs, rest, comfort, and activity. Now we want to look at the goals of intervention. The intervention for dementia, the interventions for dementia are aimed at one, promoting patient function. It's also aimed at independence for as long as possible. Though we know that the disease is progressive, but we want to encourage, we want to ensure independence as long as possible. We also want to promote patient safety because of the various behavioral challenges that we have had in the previous presentation. Then also aimed at independence in self-care activities, reducing anxiety and agitation, improving communication, providing adequate nutrition, and also providing for socialization. So we are going to look at the nurses intervention according to the nursing diagnosis and intervention. But we also need to understand in the care home, what we use is individualized person-centered model of care. And this involves the person's background, likes and dislikes in terms of food, in terms of what they do, their values, abilities. All these are taken into account to develop communication and care strategies that encourage positive responses and interaction. So the first one we want to look at in the nursing diagnosis and intervention is impaired verbal communication. This can be related to the disease condition dementia. It can also be related to age-related factors or even psychosis. And it is evidenced by inability to speak properly. At times, there will be repetitive speech. At times, asking questions over and over again. So on admission, history taking that promotes friendly, familiar, and welcoming dialogue is used. This will make the patient to feel familiar, because normally they don't like change. And when they come into the home or they are admitted in the hospital, there is need for the caregiver in the hospital or care home to make them feel at home. They will also need to orientate the patient, because it's a change environment. So when we come, we need to orientate them to the environment, especially even with their condition that they have change in cognitive function. In communicating with them, we also use simple sentences with simple words so that they will be able to comprehend what you are telling them. There is need to speak clearly and slowly. Some of the patients, they have hearing impairment. So all these needs to be put into consideration. Also, we also try to inform the patient of the care to be done for them with one instruction at a time. Because by the time you say a lot of things at a time, they will not be able to comprehend. And then when communicating with them, you use face-to-face interaction to be able to get their attention and for them to be able to understand what you are saying. Also, we need to monitor the patient for non-verbal communication. For instance, facial grimacing may be that they are having pains and they may not be able to talk. They may decide not to talk. So all this non-verbal communication is very important in caring for patients with dementia. When they are smiling, or they may be pointing to something, crying, and so on. We need to encourage them to use speech when possible. Also, we try as much as possible to avoid rushing the patient when struggling to express feelings and thoughts, so that they will be able to know that they are appreciated, they are recognized. But when you rush them, it may lead to anger, and before you know it, they begin to exhibit, to manifest behaviors that are not pleasant. The next one is self-care deficits. This can be related to cognitive impairments. It can also be related to neuromuscular impairments. And this can be evidenced by some of them inability to wash even their body parts, some inability to take off necessary clothing. So the first aspect of self-care deficit we're looking at is bathing and hygiene. So we try to provide bath chairs and stool to make them comfortable in the bathroom. And patients with dementia, we don't leave them alone in the bathroom because anything can happen. They may turn up the pipe and, many things. So you don't leave them alone. Also in the home, we try, like in Golden Age home, we try to retrofit our bedroom to accommodate them. Some will have to move in with wheelchair, bed chairs, bath chairs, and the bedroom should be retrofitted to accommodate them, things they can hold on to prevent fall and all that. Also, when taking care of dementia patients, there is need to be flexible when there is resistance. I remember an incident of a resident in the home that refused to take his breakfast and lunch because he was taken to the bathroom to take his bath. So I had to, speak to the caregiver on the cluster that for now, this resident wants bed bath. Just clean him on the bed instead of insisting on taking him to the bathroom. Until then, he started taking his meal. So at times, we need to be flexible with them when they are resistant to what we want them to do or what we think is best for them. Also, we should allow the patient to perform as much of the tasks as able. And then we give the needed assistance. Some may not be able to even take their bath at all. In that case, we'll have to do all that we need to do to ensure that they are keeping their personal hygiene. And those that can do it will be allowed to do what they can do, and then we'll finish it up. Self-care deficits in relation to toileting. We assist the patient to use the toilet as scheduled intervals. This will help to prevent the patient from urinating on themselves all the time. So at interval, 1 hour, 1.5 hours, we encourage them to use the bathroom. Also, some of the patients will have to use diapers because no matter how the schedule you try to do, they'll still wet themselves. So to prevent a patient getting wet all the time, we make use of diapers. And when they use the diapers, occasionally we check so that we don't leave it for too long that can cause another problem for the patient. We also use appropriate assistive devices like using wheelchair, using lifts, patient transfer lifts for some that cannot even move at all, that have impaired physical mobility. We use some of these devices in taking care of them. We also ensure that we maintain commode and toilet tissues close to the bedside for nighttime utilization. This is very important so that it will prevent fall. Research has made it known that there are a lot of falls in the night and is in relation to using the toilet. We also encourage fluid intake of at least 2 to 3 liters per day. unless contraindicated. However, fluid intake is encouraged during the day. When it is getting to the evening, we try as much as possible to reduce the fluid intake at that time so that it will prevent them from waking up several times to use the toilet. And at the same time, we want them to be well hydrated, because the elderly, one of the problems they are prone to is dehydration. So we encourage them to take a lot of fluid during the day. Self-care deficit in relation to dressing and grooming. We assist with cutting and filing of nails, application of moisturizers to keep the skin intact. We also ensure provision of appropriate sized loose cotton clothes to make them comfortable. Also, we assist in putting on the clothes. For those that cannot do it at all, we assist them in doing it. And then while doing all this, privacy is ensured. Another nursing diagnosis we'll look at is disturbed thought process. This can be related to change in cognitive abilities or even dementia, the disease condition. And this can be evidenced by memory loss, disorientation to time and place, even at persons. So there is need to assess the patient at this time. Some of the issues, needs they face as a result of disturbed thought process is nutrition. So we assess patient for poor nutrition and dehydration. We also try to orientate them to the environment, like I said earlier on. And then we also maintain a regular daily schedule routine to prevent problems that may result from thirst, hunger, lack of sleep, or inadequate exercise. We also ensure to help them in their nutritional need. We ensure that patients eat food. Some of the patients, if you just give them the food, they will not eat it. So there are some of them you need to sit down beside them and feed them. So the caregiver needs time to sit down and ensure that they eat their food. We also ensure that we provide well-balanced diet to boost their immunity, knowing that at this stage in their life, immunity is likely to reduce. And then food are also cut into pieces to prevent choking and then to make it easy for them, to make it easier for them to eat. We also encourage fluid intake. This is very important for the elderly. Another diagnosis we will look at is the risks for injury. I'm bringing two together, wandering and risks for injury. This can be related to being unable to recognize or identify hazards in the environment. It may also be related to mental illness or aging. And this can be evidenced by falls. They are prone to falls, or the wandering, aimless ambulation, just going up and down. At this time, we try as much as possible to eliminate or minimize sources of hazards. And some of the things we do is to ensure that fewer objects are on the floor, or ensure that there are no clusters of things on the floor that can lead to fall, and then to ensure that the floor is dry all the time. If there is any spillage, immediately we ensure that it is mopped and the floor kept dry. Also, sharp objects must be kept under lock. Scissors or any sharp object, knife, must not be left with the residents. They must be kept under lock, because They can use it to injure themselves or to injure other patients. We also ensure that we avoid sharp edges, spoons, and plates, because at times they can, when they are angry, they can throw it at anybody or do anything. So we avoid sharp edges, spoons, and plates. Medication also are out of reach. Also, we must ensure that we reduce chances of confused interpretation. What I mean is that drink bottles that they use for drink must not be used for any other chemical, so that they won't think they are similar. It's the same water they want to drink. So any similar bottle of drink should not be used for chemical or anything that will be injurious to them. We also ensure adequate lighting, especially at night, so that when they move around, they'll be able to see, and that can prevent fall or any injury. For dementia patients, we also try to ensure that they use low bed with rails to prevent fall. In some institutions or care homes, alarm system is being used. Though in Golden Age home, we don't have that. But we make use of the security at the gates. Alarm system, when there is alarm system, once they have the identity bracelet in their hands, once that identity bracelet come in contact with the door, there will be alarm, and that will make the caregivers to know that somebody is trying to go out. So identity bracelet is also used. In the bracelet, the name of the patient's address, telephone number can be used. As even for people at home, it will be very useful, so that in case they miss their way, they can easily get help through the phone number address on the bracelet. Also, we can allow wandering in a controlled environment, and that is what we do in Golden Age home. Allowed wandering in a controlled environment as appropriate or within acceptable limitation. Like in Golden Age home, we use clusters. We have clusters, and the compound is big, but the main outlet security is there, so they can't go out. So within the compound, they are free to move around. And after some time, they go back to their room. If they don't go back to their room, easily we will see them on the compound. So the next nursing diagnosis and intervention is social isolation. Social isolation, which can be related to confusion or even memory loss. And these can be evidenced by withdrawn. At times they are withdrawn, they don't talk to anybody, uncommunicative, they don't talk, they exhibit hostile behavior. This is as a result of social isolation. So some of the things we do is to allow them to play games. Some of them will play games with each other. At times, some of the caregivers will play games with them, the ones they are comfortable with. Is a source of diversional therapy for them and recreational. And then we also have television in all the clusters in some of the rooms that they can watch the program, and then they feel relaxed when they are watching the program. Music is another one. On all the clusters, they have music player where they listen to music and they enjoy themselves. Some of them will be dancing and just, enjoy themselves. And then walking is also part of what we can use. Our social workers also get involved in this, make them to walk around, involve them in exercises. Also, we ensure that we provide rest and sleep period to avoid situations that causes frustration, agitation, or sensory overload. So we encourage them to have siesta in the afternoon and to sleep at night in a comfortable room and comfortable environment. Other strategies that I use is rehabilitation services. Utilization of this skill can really be helpful. There are some of them that know how to sew before. We have the sewing unit. They go there, they do what they can do at their own time, and they go back to their room. Some of them get involved in farming, yet they may not be able to do much, but at least they're part of some of the things they get involved with, those that are interested. And some of them get involved in crafts, bead making, tie and dyeing. You know, within short time when they can comprehend, they stay there and do some things and they go. Then books and magazines are also made available for reading. We have library in the home when some of them will go there, read and leave the place to rest. So these are some of the strategies that we use. Also, medical aspect is very important. There is need to identify and treat accompanying physical illnesses. In the home, we have in-house medical officer that review and treat the residents on regular basis. And we also ensure that they attend their hospital appointments, health center appointments, so that they will be monitored even with their comorbidities. In conclusion, managing people with dementia requires patience, empathy, sensitivity, and dedication. As such, it is important that nurses, caregivers, bear each other's burden. Especially, we have heard about even the burden of COVID-19, a lot of things, new things evading. So there is need for us to bear one another's burden. That is, we should look after ourselves and each other by peer support and mentoring, and extend this support to multidisciplinary colleagues. These are my references. Thank you. Thank you.